and late, and that's just fine.
Well, good
So,
morning, everyone. This is Justin Bowditch with Better Help Together. You're listening in on the Bi-Directional Integration of Care webinar, and our presenter today, Ann Shields, will introduce herself and walk us through a few slides. So, Ann, it's all yours.
thank you, Justin. And I'm, by way of introduction for myself, I'm Ann Shields. I'm the Associate Director here at the University of Washington Ames Center. I'm a nurse by training. I've worked off and on with many of the community health centers and clinic systems around Washington State and in public health for many years before I joined the Ames Center. Um, so that's a little bit about me if you don't know me. I do want to say what I'd like. Well, I'm not really thinking about this as a webinar. I'm very interested in seeing this as a more interactive session. We've got a small group, so Justin, I think it'd be very feasible to just unmute the lines. Um, I have a few slides, and also Justin also sent you a link to the BRIE collaborative recommendations for integration as resources. So I very much want to use this time with you to make myself available for Q&A, um, help point you to any resources that will help you to develop and individualize your plan, and really help you connect the dots to resources around the state and within your region and anywhere else I know that I'm aware of that will help you make a strong plan towards bidirectional integration. So, so let's go to the next slide. Think just a little bit more about the Ames Center and our work. Um, our policy, what informs really our policy for Medicaid transformation is two areas, the BRIE Collaborative, and I was one of the work group members along with Brian Sandoval from your region, who were part of the BRIE Collaborative work group that set standards and specifications that were adopted for Medicaid transformation. So that's, I think, one of the things we'll be talking about the most today. I can answer any questions you have about those recommendations and requirements. Also, the Ames Center, we have training and support programs funded by Washington State. The Integrated Care Training Program, ICTP, um, that's all around behavioral health workforce development for both specialty mental health as well as primary care settings. So if you have any thoughts or questions about that, those are resources that would be available to your organization free of charge. And we're very excited that as of July, we'll be able to expand those resources to include a wider group of providers. Thus far, we had been limited to working with psychiatrists and psychiatric providers. And now we're going to be able to work with a broader array of providers that work on teams supporting bidirectional integration. That'll include nurses, social workers, others. So ask me any questions about that, because I think that's something you could think about how to use that within your plan and potentially get more leverage out of those resources that are available to you. I'll talk a little bit today also about some of the larger Washington State integration implementations that we've been involved in. The Mental Health Integration Program, many of the community health centers in your region have been a part of that program off and on. And also the Providence region on your side of the state, Spokane, has been one of the very early adopters working with our ICTP program to bring collaborative care on board and offer that in your region. So they're a great local resource. I don't know if anybody's on the line from Providence today in Spokane, but if so, let us know in the chat box, because it would be great to hear from you and hear your local perspective on that. Let's go to the next slide. So just to step back here, what's our overall goal? What is Project 2A supposed to do? Really, I like to think of this as your strategy for supporting whole person care. And this is a triangle that we sometimes use to really represent the array of services within your county and within your region that your plans will have to consider and take into account. Obviously, those community-based services and supports, concerns for adequate housing, all of those concerns are at the bottom and a very big part of this pyramid in order for individuals and families to get the services and support they need. So moving up this triangle into the primary care world, we often think of the primary care provider as sort of the front line for many behavioral conditions. PCPs are often the first to see and diagnose common conditions like depression. In fact, 80% of depression is actually diagnosed in primary care. On the other hand, for those who have serious mental illness, they're much more likely to encounter the need for whole person care up there in that green region at the top, because they're much more frequently seen and often best served in a community behavioral health setting. So is anybody hearing a little static on the line, or is it just me? Justin?
You can go ahead, Ann. I think I've taken care of it.
Okay, all right. I'm hearing it, so just to check. Okay, so though we put community behavioral health at the top of the pyramid, in some ways that really represents that there's a smaller number of clients and patients who are typically going to be served in a specialty setting and who can be best served in a specialty setting. Joe Parks, who's the medical director for the National Council and who founded the Missouri Health Homes program for community behavioral health agencies in Missouri, he likes to say that people should get their care where they're most comfortable and they feel most at home. So I often like to use the term health home. I don't often say medical home or patient-centered medical home anymore. I really, because our state is moving to a whole person bi-directional concept, I like to use the term health home. So consider that as you develop your plan. Any questions or comments about that from anybody on the line in the chat box? Okay, I'll go ahead and I'm going to move back and say a few words about the blue section of this triangle, because I know you have many providers in your region that use a behavioral health consultant, or what's sometimes called a PCBH, primary care behavioral health model, in primary care. So that's a great model, and it's really reaches a lot of patients within your clinic, within a primary care setting. That consultant, who typically an experienced social worker, might even be a psychologist, is available to really work alongside the primary care provider and help patients to address a wide variety of issues, often not diagnosable behavioral health issues. They might be assisting in areas like smoking cessation and anticipatory guidance for teenagers, for example. So that's a great, very broad model that reaches a lot of patients, a lot of clients in a general way. However, it typically provides only short-term support. You can't really you can't expect that consultant to do lengthy or in-depth treatment or support for your most complex patients. Those, for example, with a more serious and persistent mental illness or perhaps opioid use disorder. So because it's a brief intervention model, oftentimes we've seen very strong programs that step both consultation but also offer a collaborative care program that offers more intensive support over a 2 to 6 month period. So now, what's your alternative? If you're just using a PCBH model or you're just using a consultant, your decision point is, are you going to refer out anyone who needs more in-depth care, whose diagnosis and circumstances suggest that they're going to be needing more intensive services for 2 or 6 months or longer? So I would say for each of you in planning your strategies and your model of care, this is one of those key decision points about thinking about whether or not you want to offer uh, more services and consider how to step the intensity of services a patient receives based on their needs, or you want to partner with outside referral sources or other agencies to do so. So, any comments or thoughts on that before I go on? That's a little bit complicated, but I think it's a key piece for each of you in planning your response for 2A. So we'll go on to the next slide then. Okay. And again, no one approach is going to fit all your needs. One of the, I think, sometimes deceptive aspects of the way the toolkit has written about the BRIE collaborative specifications and the collaborative care model is it sort of looks like you are being forced to choose. And in truth, you don't really have to choose. You're going to need to adapt the best aspects of these so-called models to your local needs and to the workforce you have available. So really, we like to say that arguing about the best integration model is a little bit like arguing about whether it's what's the best religion. In fact, I don't even like to use the word model. We like to use the word strategy. So I just want to make that point because if you're looking very strictly at the Medicaid toolkit, you might see a requirement to make a choice earlier than necessary. Okay, let's go on to the next slide here. Whatever so-called model you decide you'd like to emulate and adapt to fit your needs, there's some core principles for evidence-based integration that are very important for you to pay attention to and think about. And I'll spend the rest of the slides here really going through these in some detail. The same principles apply for all strategies you might consider. Team-based, person-centered. You see in the Medicaid toolkit the requirement of using shared care plans to support whole person care. I'll circle back to that as we share some tools for doing that. Population-based and data-driven, i.e. having a defined group of patients or clients tracked in a registry of some kind. That's, again, called out in both the BRIE specifications as well as in the collaborative care model. And I'll talk a little bit about what are your options for piloting that and using that. Measurement-based treatment to target. If you only remember one thing I say this morning, this is the phrase. This is what you need to think about and reflect in your project plan, and you really need to carefully develop in your model of care. And we'll talk quite a bit about that later. This is, again, called out in both BRIE as well as collaborative care model information that's on the AIMS website. So let's go ahead to the next slide, which is really just basically the next slide is a crosswalk for Project 2A. And thinking about what are those same elements of behavioral health in primary care settings. So basically, Justin earlier sent you the BRIE, a direct link to the BRIE report. Now, the BRIE report's like, 45 pages long, lots and lots of information in there. It's a bit overwhelming, frankly. What you need to look at and pay attention to in your planning is Table 6. And Table 1. I've got a misstatement on this slide. It's actually Table 1 on page 6 of the BRIE report, so I'll correct that. And that's the specifications for integrated care and looking at the column about the operational details for integrating care. In a nutshell, these are outlined here. And these are virtually the same as what you would find on our website or elsewhere describing the collaborative care model. Bringing in a behavioral health provider is a key part of the primary care team. That person could be nurse, social worker, psychologist, a wide array of trained clinicians and staff. Using systematic screening, such as the PHQ-9 and the GAD-7 for anxiety. Other screeners you might be familiar with, the DAST and AUDIT for substance use. Using systematic screening in a more consistent and often a more frequent way. Also, measurement-based, as I mentioned earlier, i.e., for those who are diagnosed with a common condition, let's say depression, you use the PH9 to measure their symptoms and their level of function, and also any risk of suicide. So it's using measurement in a very different way than you might be doing now. Not as an annual screening, but consistently for those with the diagnosis. Then population-based care, I'll talk about that more as we get to that registry example. Treatment to target. This is like a big game changer. Called out again in both strategies, treatment to target. This concept that you can do a whole lot better by your patients with behavioral health conditions than you're doing right now, potentially. If you're doing usual care, i.e., the PCP doesn't really have anybody to help, there's not a clinician on staff, so they're kind of punting on their own. What usual care looks like is often that someone's handed a prescription for an antidepressant, goes home, nobody follows up, or nobody follows up very quickly. So oftentimes that patient doesn't hear back for 3 or 6 months. We know from many studies that we can do a lot better, and we can help people, we can alleviate those symptoms much more quickly, usually within 10 weeks with more intensive behavioral health care management. And we also have to use tracking systems to be able to really follow up much more persistently and proactively than we typically do, utilizing evidence-based treatments. And now the last bullet on this slide is really the only place where the BRIE collaborative and the collaborative care model differ a little bit, and that's in how they apply and use psychiatry services and allow access to psychiatry. The BRIE table specifically calls out that primary care practice must create access to psychiatry services. And in the collaborative care model, that access is often created through a case review strategy that spreads the psychiatry provider over an entire caseload of 50 to 100 patients or more. So I won't get into the weeds on that, but I'm happy to follow up with questions about how those delivery models vary a little bit. Okay. So let's go to the next slide. Any questions at this point? Any thoughts about that on the primary care side? You could chat, or do you want to unmute the line for a minute, Justin, just to see before I move on? Okay. I'll move on to what I think of as sort of the flip side and the other important, really big part of Project 2A, which is primary care in behavioral health, i.e., managing common medical conditions in community behavioral health settings or other settings that are serving those with more serious mental illness. Really the behavioral health home side of the coin of Project 2A. The same principles apply. The Medicaid Toolkit asks community behavioral health to use collaborative care principles, same principles as my previous slide, essentially. Toolkit also offers other options to consider, and really these have to do with whether or not you create primary care support through a collaboration, a partnership, or you build that capacity in-house. So offsite, enhanced collaboration. I can give you several examples of how that might work, but I'd really rather hear from you if there are any examples or ideas you have about how that collaboration might fit for your particular agency's circumstances. Co-location. Co-location is a great starting strategy. What we see in many studies is, what drives co-location to actually really work is very strong shared treatment strategies and shared treatment planning. So, co-located and fully integrated care. So obviously there are many challenges here, and I like to say that we also know that our behavioral health agencies have a bigger lift. They've got a steeper learning curve than many of our primary care settings do in our state. They've made the transition from RSN to BHO. Now there's another transition as managed care has direct contracting relationships and more influence. So heavier lift in many ways. I think looking at different pilots and partnership strategies, some of the successful models we have in our state and elsewhere can be very useful to you. I'll talk more about that later if you're interested. So I want to finish covering the principles though. So next slide is a little bit more of an in-depth view about what it means to do measurement-based treatment to target. This was defined by the Kennedy Forum several years ago as involving the systematic use of symptom rating scales to drive clinical decision making. The Kennedy Forum report on this is, I think, from 2015. Since 2015, we've seen NCQA adopt measurement-based HEDIS measures using the PHQ-9 to reflect patient outcomes in remission and depression, for example. So this is really a huge shift in how we provide behavioral health services in our state. There's very good evidence that symptom severity should be assessed much more frequently and oftentimes shortly before or at the start of every clinical encounter. But right now we know that only about 18% of psychiatrists and like 10% of psychologists actually routinely administer symptom rating scales. We're seeing that change very rapidly now. As more Medicaid ACOs are starting up on the East Coast, we're actually seeing many of the safety net settings that we're privileged to work with here at the AIMS Center. They're actually starting to use the 9 at every patient encounter, which is a great practice, but it's a really big change in workflow for everyone involved. So that's a very key part of what you're going to be asked to do differently as you develop your model, moving towards fully integrated managed care. So the next slide is a little bit about strategies for population-based care, i.e. thinking about all of your patients in different groupings with common characteristics, and how are you supporting them? So this is really, I think about this as sort of a triple aim strategy that's very important here. So tracking systems and registries don't have to be too complex, but they have to support proactive tracking, active treatment that helps you stratify and identify which of your patients and clients you need to pay attention to today or this week, so that nobody's falling through the cracks. If you're interested in learning more about how you might pilot this or PDSA this, if you're not doing this currently, we actually have a free spreadsheet, and there's a link here on this slide to download it. You can also just Google your way to it. We've got a patient tracking spreadsheet that's been downloaded over 3,000 times around the country. In Australia and also in Sweden recently. We're really proud of that. It's free. We're starting office hours soon for spreadsheet users. I will say we've got spreadsheet users in our state that use this alongside other builds in their EHR. For example, some of the Providence regions are still using a spreadsheet to make sure they capture their caseload. UW Medicine is using a spreadsheet to make sure it separately captures its pediatric caseload, for example. So don't discount it just because it's low tech. We do also offer a caseload tracker that you'll also find on our website if you'd like to look at that. So just to walk across this spreadsheet a little bit and give you an idea about what you want to do, whether you're using a spreadsheet tool that you develop or you check out ours, or whether you're using frankly, a box of cards on your desk to track your caseload. You're going to be looking at their treatment status, how frequently have they been seen, how long have they been in treatment, i.e., are we going to be able to meet their needs in primary care? Usually if someone is treated in primary care for around 6 months, even in an intensive collaborative care management program, 6 months is where we start to think, if we're not getting them better, maybe it's time they move into specialty care. They need more intensive services than we can provide. Okay. Now, this particular spreadsheet example uses the PHQ-9 for depression signs and symptoms, and also the GAD-7, anxiety. You don't really need the GAD-7. A lot of people like to track it, but if you like to keep things as simple as possible, if you use the 9 and you use the GAD-7 to help distinguish the diagnosis, so you're understanding what features might have to do with anxiety versus a depression diagnosis, you're still going to be fine. But many people like to track both, so we have it here. The far right column of this spreadsheet includes psychiatry consultation. Now, this spreadsheet is set up really to support a collaborative care model. However, you could really use this side of the spreadsheet to just track psychiatry access in a more general way. So it's just a way for you to understand whether or not you would have included a psychiatrist in planning and any kind of a curbside or other consultation. And then those colored sections where you see a red, which basically means like this person is at risk, a safety risk. There needs to be a plan for this patient in the chart that everyone is aware of. And yellow, you see where a primary care provider has asked their clinician or other staff member to basically flag this person for discussion with a psychiatrist. Okay, so that's a little example of how a tracking sheet might work for you. So let's go on to the next slide. And I'm just really about done here unless you've got questions and ideas or to share. It's one thing to say with the prophet Amos, let justice roll down like mighty waters. It's quite another to do the hard work you're starting about building out that irrigation system. So I love this quote. We've spent the past decade working with really diverse range of organizations to work out their irrigation systems. And at the AIM Center, we've really learned quite a lot about what works and what doesn't. And I'm very happy to share any ideas or lessons learned the hard way with you all. And I know you can also learn as much from each other as a learning community as well. So really appreciate the opportunity to be on the line with you today and see if we have any more resources or other ideas that would be helpful to you in building your project plan. So my next slide is just a reference to send you to the AIMS website. If you're interested, and to the Integrated Care Book is particularly might be a useful tool as well. We have many tools and like sample job descriptions, sample contracts for behavioral health agencies who might be working with a primary care practice. For example, you're free to download those. If you can't find something on the website, you can always email me, and myself and our webmaster, Brandon, will definitely try to point you in the right direction if that's useful to you. And then last slide, and we'll just open it up for any comments or questions. I truly believe that enlightened trial and error beats top-down planning any day. So I really do encourage you to pilot and PDSA your way to what you think will be your best and most successful strategies for bidirectional integration. And we're happy to help you think through what might be your best start if you're wherever you're at, or any tweaks you might want to make to your existing model of care. So, so that's it from me. I wanted to, Kathy had asked me to save most of the time here to respond to questions or just open it up. Let's just go ahead and unmute and see if the sound quality is okay when we unmute. And if there are any lessons learned to share or any direct questions I can help with.
So, Anne, can you hear me? This is Ron Stock. Good morning.
Yeah.
Yes, good morning. So I have a couple of questions and maybe some comments also, but I was wondering if you could maybe talk about care agreements or collaborative care agreements and whether folks have used that as a way to communicate with specialists, particularly psychiatrists. I know that in some other initiatives nationally, we've been using care agreements with specialists to help understand kind of the mutual responsibilities between either the primary care practice, but maybe in Eastern Washington and other places, just between substance use disorder clinics and behavioral health or mental health clinics and specialty care. It's generally the care agreements can be they're not really contracts, but they're sort of MOUs about this is how we're going to interact with each other to communicate and share patients together. So I'd be curious as to how your experience with collaborative care agreements.
Well, I haven't, and please, those on the line, if you have experience with that in our state, please do speak up. My experience in the last decade has been much more formalized agreements, and that's driven in part because of, one, the cost of psychiatry access, as well as privacy concerns for the patient. So, for example, we have on our website a sample contract that was that's posted with permission from one of the larger FQHCs and their behavioral health provider, Valley Cities, that outlines very specifically how they work together. And so that agreement includes a typical agreement in our state, and a preference I hear from many primary care providers is to have at least some hours of psychiatry time in clinic if that's feasible. That might be 4 to 8 hours of a psych NP or a psychiatrist. I want to point out that you might also consider a physician assistant, a PA in that role, who's working under the direction of a psychiatrist. We're starting to see that used in the state, in our state, as well as elsewhere. In fact, we have a PA enrolled in our fellowship program now. So, but I've generally seen not an MOU strategy, but or maybe MOUs used to sort of develop a relationship, but frankly, it's moved pretty quickly to more of a contractual to guarantee certain hours and access. Sometimes the 4 to 8 hours of a psychiatry provider in clinic is coupled with management of, and that can be remote management of a collaborative care caseload. Many of the CHCs around the state have had that model in place off and on for some years now.
Yeah, and I'd be interested if there were any mental health clinics that had these kinds of either contracts or MOUs with primary care clinics or PAs or physicians that might come in or provide services externally.
I am not familiar with any in the Spokane area. Is there anybody on the line who can speak to that? That doesn't mean they don't exist because they're not on the line. Those I'm familiar with are, one example, well, a couple of examples. One example is a partnership over in South King County that is with Navos. and with the local public health department, which is also an FQHC, has FQHC status. So NAVOS has a contractual arrangement that brings medical staff into their campus in South King County. And they provide a team-based model that covers both comorbid medical conditions as well as addressing serious mental illness for those patients. It's basically an adaptation of the collaborative care model. So that's one good example. And if anybody wants to hear more specifics about how that works, I'd be happy to introduce you to the managers who set that up and have developed that, because that's been in place for 5 or 6 years, right? The Missouri Health Homes model is another strategy to look at for mental health settings, which really includes a partnership. A less formal partnership is based around a nurse care management model. There's lots on the web that describes the Missouri Health Homes model. When we worked with the Washington Council here in our state to develop a training package that might be useful, we paid a lot of attention to that model because it's very much health home based in community mental health, and with a nurse or a team that covers those nursing functions, really becoming the communication hub and the link to a more comprehensive primary care provider. So those are two really good options to think about. Okay, other questions or comments? Or I'd love to hear just even what people think, or what direction you think you're going, Bree or otherwise. It'd be great to hear your ideas at this point, or your plans, I guess. So, I'm wondering if anyone has, I know that Justin sent out a link to the Bree specifications. Would that be useful to talk about a little bit? Does anybody have any questions about that?
So Anne, this is Rod again. I actually have another question for you. It doesn't
Sure.
sound like other folks have other questions. But I was wondering if you could, one of the biggest barriers to the there's establishing good communication lines is a really critical piece to team-based care or whatever. But one of the barriers, particularly between substance use disorder clinics and primary care, are the sharing of information, HIPAA Rule 42 CFR. I was wondering if maybe you could just comment about that from your perspective in Washington.
Well, I'm going to start with a caveat. There's lots. I'm not an expert in 42 CFR. There are lots of state opinions, state-level privacy laws, and interpretations of 42 CFR vary. In our state, we've had a long history of state privacy laws that allow contracting providers to share information among treating providers. So, for example, when we started about 10 years ago, we had a program that has, since become part of Medicaid services that allowed a shared care plan registry, online, HIPAA compliant, to be shared between treating providers, whether they were in specialty mental health or in primary care. And if you Google on our website, you'll see the caseload tracker on the AIMS website, which we're licensed pretty much at cost to any Washington provider. We've seen arrangements in our state previously, and also in other states, where this kind of a HIPAA-compliant online tracker can really be shared across treating providers very effectively. The Medicaid Toolkit asks you to develop and work towards a shared care plan in some way. I mean, we all know how challenging that can be without good tools for that. So I would suggest you look at that. Um, we're actually working with a number of ACHs who are going to be covering the license of the caseload tracker for some of the practices that want to trial it at least. No commitment, but just to trial it at least because it's at relatively low cost. And it has some advantages. So really, I don't have I think 42 CFR is still considered challenging, especially around opioid use disorder and addressing that. But I don't know, Ron, if you have some advice on that or concerns to share that people should be aware of, you're very welcome to do so.
Yeah, no, I see Brian is on the line. He might want to comment a little bit about
okay.
this too. But in Oregon, we actually set up a sort of a statewide a group to address that we could get some kind of consistent sort of standard approach to how organizations were going to share information and kind of address that. And I thought maybe Washington had done the same thing. But I think getting some clarity, as we've interviewed clinics, like in the both in primary care and mental health clinics, it's a barrier. There are some myths out there about what it is, and so I think kind of creating a lexicon of common language about what you're talking about and what the real rules talk about. And I think there is a component of education to make sure everybody's on the same page about what that means, and that can be helpful.
And what's interesting about that is, I think and Brian and I have talked about this previously too. In some ways, I felt that Oregon was, I guess, organized in a way where you were a little more able to move forward in a statewide way on some of those issues. That would be hugely helpful here. But right now, we're, I think, a few years behind Oregon in developing our structure, and we're so regionalized that it's harder to create those statewide conversations that I think probably are best done at that level. So that would be great. Maybe we can work on that together at some point.
This is Brian. Can you hear me? Can you hear me at all?
Yeah, Brian.
Yeah.
So one of the things that I think we found just at the practice level is if you're really intentional about 42 CFR, a lot of it can be mitigated through workflows. And I think one of the things that we've tried to work on, because we also have a specialty behavioral health and chemical dependency arm within our organization, is just making sure that we make it a standard practice to get releases up front and be very clear about our intentions with those. Obviously, there's going to be people that opt out, right? And that's part of it. But I think what we've learned is that if we just kind of make it a standard practice and we develop really good workflows, that a lot of those issues take care of themselves. Obviously, that doesn't, it doesn't take away the barriers that are at the state level, but at least at the practice level and kind of sharing how we are doing things with local partners can kind of help, I guess, mitigate some of those challenges.
So, Brian, one of the things we're planning, the AIMS Center is also working to support the SDR-funded opioid treatment networks, all of which are currently on the west side of the state, but the east side is, many agencies are right now preparing applications for east side treatment networks. We are planning already a webinar and some resources later this summer for everyone around 42 CFR, and really we've tried to create sort of a way to trade best practices and workflows, and we'll definitely involve you in that if you're interested, because there's no reason for people to be reinventing the wheel if someone's already figured out a best practice there that we can all adapt.
For sure.
Now, I'm going to ask another question about that. What I've observed in many parts of the state is that this is really around opioid use disorder treatment, medication-assisted treatment. We see some agencies that consider that part of their behavioral health program and responsibility of their behavioral health team to provide care management, assessment, and support, and others who completely segregate it and handle it very differently. Any thoughts on that? Is that really seen as part of an integration strategy, or is it really handled very separately? The Medicaid toolkit sort of puts it in a different bucket, which I think kind of invites people to think of opioid use as somehow different than other behavioral health issues, but they're really all very connected. So, any thoughts on that, or Brian, or anybody else?
I don't have anything to add right now.
Okay. All right. Well, if nobody has any other big questions or comments, or even little ones, we could end a little early. What do you think, Justin?
Sounds good with me. Last call for questions, folks on the line. Well, Anne, we thank you so much for talking a little bit with us about the Bi-Directional Integration of Care Project. For those that have called in, we will have this webinar recording available quite soon.
Thanks, everybody. Good luck on your project plans, and anything else you're working on now. Happy to help if we can provide any resources. Thanks. Bye-bye.
Thanks, Anne.
Bye.